Hey, welcome back to another Coach's Corner here, where I'm here with Dr. Sean McBride, bringing up various case studies from our real world practice.
Yep.
So I've got an athlete who, and several actually in this instance, who've come back from sport, skiing, jiu-jitsu, whatnot, coming in after an MRI with a meniscus tear, cyst, maybe early onset arthritis. And I wanted to just rope Sean into this conversation and be able to look at it from a clinical perspective and how we would break each of these topics down.
Yeah, absolutely. So I want to kind of take each of those a little separately. So we're going to take the cyst and the meniscus as kind of one thing, and then we'll talk about the arthritis in a separate thing. So they're actually kind of different problems and different management. So when we're thinking about a meniscus, first, the meniscus is a cartilage that is right on the bottom half of your knee joint, helps to cushion your knee, it cradles the knee, so it makes it, assists in the stability, and it's particularly vulnerable to shearing. So if you have kind of a slip where the top half of your knee slides over the bottom half or twists, that's the kind of movement that will tend to damage that. And then what happens is you become incredibly sensitive to those types of movements. So even the smallest amount or even normal amounts of movement in the knee become very sensitive. A lot of times there's a lot of swelling and a significant amount of pain associated with an acute meniscus tear. And so basically from the coach's standpoint, it's not your job to rehab that. It's not your job to fix it. The body will usually become, you have to work through the inflammatory process. There's a healing process that goes on, and usually over time you become able to resume. And the standard management for meniscus tears is no longer to have a surgery. It's actually to manage it conservatively unless the tear is so severe or in such a sensitive spot that you can't progress past that without some type of surgery. So ultimately, whether you're involved in the acute rehab or the long-term rehab, as a coach, you're working with a lot of people who have some type of meniscus tear in there, whether it's old and cold and it's no problem at all anymore, or whether it's something that's more recent. So if you're dealing with something more recent, whenever we're thinking of a tissue that's primarily involved in stability, if you damage it, you have a stability problem. So how we manage stability problems is by creating more stable positions. So step one is isometrics. We're gonna fix the knee in place. It doesn't mean we take all lower body movements out of it, but you wanna demonstrate that athlete needs to demonstrate to themselves and to you as the coach that they can handle isometric knee positions. So we're thinking stiff leg deadlifts, Romanian deadlifts, things where you're not actually bending the knee a lot. And you might even progress before you go on to any type of squat to a single leg deadlift where there's a stability challenge, but you're actually still locked in place, right? You shouldn't be moving the knee. And sort of taking a small step back, what proves that you're handling it is what we call tolerance. And when we say tolerating, what we mean is you're not having pain or swelling increases during that activity or for about 24 hours afterwards.
Now, you mentioned swelling. So how would we address swelling in this situation?
So all the tools available to you as a coach are available to handle swelling. So that's compression, whether that's a knee sleeve, which can be really helpful in a case like this. You can do a voodoo wrap. Love any sort of sequential compression like the H-Wave or other machines or devices that provide that type of compression. I think this person should be religiously and routinely wearing this probably 4 to 6 hours a day.
So almost like managing swelling like it's their part-time job.
Not part-time, full-time.
Full-time job, full-time job.
Full-time job.
Lucky you.
Because if you have swelling in a joint, there's no way that joint is working normally. Until you get that swelling out, swelling is the genesis for pain. It's just a big roadblock. It's a big stick in the spokes. So it's very difficult to get on to those things where you get to start moving and using your body again as long as swelling is present. So that's a huge, huge first step to taking care of that. And then once you've got that and you start to get the ball rolling, we want to go to very slow tempo movements over very slow ranges of motion. So we're thinking hinging variations at slow tempo, weight kind of a secondary consideration. And you just build that step by step. slowly increasing the range of motion as tolerated, slowly increasing the weights as tolerated. Everything's just very careful, just making gradual steps towards that kind of full return to function. Speed is the last piece of the puzzle.
Right. So what I'm hearing then, kind of to, sum this piece up is,
Yeah.
we're looking at acute injury. We want to manage the swelling by
Yes.
getting the fluid out,
Yes.
right? And then once we've gotten the fluid out, it sounds like we're almost just taking the knee out of the equation for right now.
Right.
Right. Lots of isometrics, kind of building the stability externally, right?
Right.
So we have to focus internally. And then really being able to find ways to move that don't involve a lot of kind of shearing or movement through that knee particularly.
Right. Not a lot of jumping lunges first week.
Excellent. So we'll come back with part 2 and we'll talk about cysts and arthritis.
Sounds great.